Hello, good morning, everybody. Today we are going to talk about the Perthes disease. This is a disease of childhood, which is very common but quite often missed in diagnosing. So, the other name is a late calf Perthes disease, first described by Storm in 1909. And during the same period, in about 1910, three people, all three were orthopedic surgeons, and they were LEGG, CALVE, and PERTHE'S, describe the same thing, which is LEGG, Perthes disease, right? And what is Perthes disease? You have coxsaclena, pseudocoxalgia, osteochondritis deformis coxa juvenalis, and osteochondritis capital femoral epiphysis. Perthes disease is a condition which is pathologically characterized by idiopathic avascular necrosis of the epiphysis of the femoral head in a child. As I told you, it is a disease of childhood. The avascular epiphysis is almost always completely revascularized and replaced, but resulting in variable amount or degree of deformity of the femoral head and growth disturbances. Now, if we talk of the epidemiology, it is common in Central Europe, less common in Blacks and Chinese and Indians. Quite frequently in rural southwestern coastal areas of the India, and it is 10 times more common in Pudupuri area of Karnataka than Vellore in Tamil Nadu, which are the prominent areas of occurrence of Perthes disease in that population. If we talk of the incidence of the male-female ratios, so males are affected 4 to 5 times more than the females. Now, what is the age at which it occurs? The most commonly seen in age about 5 to 10 years of age. And the mean age is higher in the South India, which is in males is 9.9 years on average, and in females is 8.7 years. Now, when we talk of the cause or the etiology of the Perthes disease, it is said it is a temporary and possibly repeated vascular insult. Vascularity of the head of the femur is inserted repeatedly, leading to the etiological or the causative factor for the Perthes disease. Though the precise cause of insult is very obscure, and hence it is called as an idiopathic disease. Now, both developmental and environmental factors which make the child susceptible to the disease are, which are the proposed theories, though it has not been confirmed, are inherited protein C with S or without S deficiency, venous thrombosis, arterial occlusion, or the anomalies of the arterial supply at that area, and raised intraosseous pressure within the head of the femur, or it may be a contributory factor by the synovitis of the hip joint. Now, how the things progress, or how the pathology develops, or how the changes take place due to these causes. So, the histologic changes were described by 1913. In 1910, it was diagnosed and labeled with the name of their discoverer, And by 1913, the exact pathology or histologic changes were known to the orthopedic world. So the secondary ossification center is covered by a cartilage of three zones. Okay, and those three zones are the superficial, the epiphyseal, and the thin cartilage zone. Now the capillaries penetrate the thin zone from below, and as you see in the figure, articular cartilage, the outermost articular cartilage, which is articulating with the scapula, then you have got a superficial zone, then you have got a middle zone, then you have got a deep zone, and deeper to this is the epiphyseal plate, and then the metaphyseal area of the proximal end of the femur starts. Now, if we go into more details of the pathogenesis, we will talk of the superficial zone is normal, but it is thickened. This is the changes which is occurring in the cartilage. Now, the middle zone has an area of hypercellularity, which is not uniform, but it is in clusters. And number two, areas of loose fibrocartilage matrix is also seen within the middle zone of the head of the femur. Then you have got a superficial and middle, then we know that the superficial and the middle layers are nourished by the synovial fluid diffusion. And the deepermost layer is supplied by the blood supplied by the arteries. Now, the epiphyseal plate changes are there is a cleft formation in the epiphyseal plate, there is amorphous debris develops there, and the blood is getting extravasated. In the metaphyseal area of the proximal femur, normal bone is separated by a cartilage matrix, and the epiphyseal cartilage or the epiphyseal changes can be seen also in the greater trochanter and the acetabulum, though they are not the basic primary area of pathology, but the second changes do occur there. Now, the disease was before stages. Bone remains there is the residual stage. Then we come to the stage of necrosis. So what happens? There is ischemia. A part, either anterior or whole of the capitular femoral epiphyse is necrosed due to ischemia, which on X-ray looks